Good evening, friends. I would like to be. Am I audible? Hello. Good evening, colleagues, friends, seniors. I am very thankful for the opportunity to be here in front of you today. It's a pleasure to be with so many pediatricians to discuss an issue that touches every OPD and ward round: the role of right antibiotic dose in pediatric community-acquired pneumonia. I'm very sure many of us have treated at least one case of pediatric community-acquired pneumonia in this last week. So before we go further, let us see how the global and Indian burden is in childhood community-acquired pneumonia. Globally, community-acquired pneumonia still causes 15% of all childhood deaths and nearly a quarter of pediatric hospitalizations. India alone bears about 23% of the world's pneumonia burden, with 4 million cases annually. Frankly speaking, the proportion of community-acquired pneumonias can vary from viral to bacterial. But it's very difficult for us to, at the onset, decide whether this is going to be a viral or a bacterial and what we are dealing with. So even in the under 5 age group, if you see, the viral pneumonias are more common, but frankly speaking, it is very difficult for us to know whether it's a mycoplasma pneumonia or an RSV, and we really don't have the time in the routine busy OPD to discuss and decide whether we are looking for a viral or bacterial. In the under 2 years age group, streptococcal pneumonia and H. influenzae are the most common bacterial pathogens, while between 2 to 5 years, strep pneumonia and H. influenzae, and above 5 years again, strep pneumonia and H. influenzae. The atypical and the viral pathogens being M. pneumoniae, RSV in the most common order. Being the leading bacterial cause of community-acquired pneumonia in children, strep pneumonia and H. influenzae, we usually have to treat them in the way that our diagnosis is not missed. We give on time the right treatment and the right dose, and that's what we are gathered here today for. Before we delve into the treatment, let's talk about the risk factors and complications of pediatric community-acquired pneumonia. Beyond microbes, there are social determinants like poverty, indoor air pollution, low birth weight, which fuel the disease. There are socio-economic factors, genetic, biological factors, environmental factors, and the complications which we see in the same order would be pulmonary, extrapulmonary, and systemic. Pulmonary, we see pleural effusions and empyemas. Extrapulmonary, there is meningitis, pericarditis, endocarditis, and systemic inflammatory response syndrome, or SIRS, as we usually know, sepsis, and HUS. On the basis of diagnosis, we usually have a set protocol as to how we deal with upper respiratory and lower respiratory tract infections. So I think classifying pneumonia is something which I do not want to waste time on teaching anybody or talking more about it. But yes, we have no pneumonia when it comes to cold and cough, pneumonia when we have fast breathing and chest indrawing, and then severe and very severe pneumonias which have the general danger signs like unable to drink or feed, persistent vomiting, convulsions, cyanosis, etc. So when we talk about diagnostic workup of community-acquired pneumonia and OPD cases, there is routine blood work. If the cases are complicated, but in uncomplicated outpatient pneumonias, routine blood work is usually skipped. For patients not responding to previous therapy, and we are looking for empyema, we look for chest X-rays, blood cultures, CBC, CRP, and ESR, RSV or rapid influenza A or B tester. Pulse oximetry spot check is also pretty diagnostic if we are looking for less than 93% of saturation. Actually, the guidelines which usually recommend lung ultrasound, it is a better first-line imaging modality without radiation exposure, unlike X-rays. But in today's world, I think many of us would still be not using ultrasound to diagnose empyema or pneumonias, judging more on our clinical acumen, and then going on to the first line investigations like blood and X-ray, rather than jumping to an ultrasound on the first basis. But I think it's not the lack of knowledge or it's not the lack of initiative that we are doing that. It's usually equipment or unavailability or the financial causes for which we are postponing the using of ultrasound for empyema. Going towards the management of pediatric community-acquired pneumonia, all major guidelines, that is WHO, IAP, PIDA, agree that amoxicillin is a first-line management with escalation to amoxiclav when resistant organism or beta-lactamase producers are likely. In our setting, how often do we initiate to amoxiclav or amoxiclav high dose at the first onset? As a recommendation, all of us known to be good clinicians, we usually try to restrict the use of antibiotics only when required, when it is very essential. So even when we start with amoxicillin, we usually start with the amoxicillin dosages of 40 milligram per kg per dose. If we want to talk about a child between 2 to 59 months of age with cough and/or difficulty in breathing, we diagnose it as no difficulty in breathing, then goes to no pneumonia. But there is rapid breathing, it is a pneumonia, then we usually start ambulatory treatment with oral amoxicillin on an OPD base. But yes, with rapid bleeding and there are danger signs available, then severe pneumonia is treated as an IPD based case. The empirical antibiotic therapy for OPD based community acquired pneumonia, for patients younger than 5 years, our obvious first line has always been amoxicillin. If we are thinking about an atypical cause, then we go towards azithromycin. As an alternative to plain amoxicillin, oral amoxiclav is used with 90 milligram per kg per day in 2 doses, and alternative to that again becomes clarithromycin. In patients 5 years or older, there is first line is again amoxicillin, and alternative would be oral amoxiclav 90 milligram per kg per day in 2 doses. Again, first line as azithromycin and alternative is clarithromycin if we are presuming an atypical cause. In non-severe pneumonia, oral amoxicillin, as I mentioned, 40 milligram per kg per dose twice daily, that is 80 milligram per kg per day for 5 days is usually enough. In cases where we think that plain amoxicillin might not really help, we usually step up to amoxiclav as it is more effective than amoxicillin. In most pneumonia cases can be diagnosed and treated with oral antibiotics at health centers or by trained community health workers. Hospitalization is recommended only in severe cases of pneumonia. Empirical antibiotic therapy for OPD community acquired cases, for 3 months to 5 years of age, amoxicillin 80 milligram per kg per day for the first 5 days is the first line, or co-amoxiclav with the dose same as amoxicillin, or cefpodoxime or cefuroxime is used. For patients 5 years and above, amoxicillin is used in an oral dose 40 milligram per kg per day. 40 to 50 milligram per kg per day is sufficient, as we have a prevalence of penicillin resistant pneumococci. Co-amoxiclav schedule is the same as second line with cefpodoxime or azithromycin. If Staph aureus is suspected, co-amoxiclav with the dose same as amoxicillin or linezolid for 5 days in TID dose is also recommended. But usually linezolid is a reserved drug we use for tuberculosis, so NTEP is advised to use it with caution. Let us discuss the role of amoxicillin clavulanic acid in community acquired pneumonia. India has the largest global mortality for children under 5 due to community acquired pneumonia. Mortality rates less than 5% for outpatients and 10% for hospitalized, and more than 30% for ICU is seen. Common pathogens being strep pneumoniae, H. influenzae, S. aureus, S. pyogenes, and atypical bacteria. S. pneumonia being the most prevalent. We usually tend to look for something which gives us a broad spectrum coverage, low penicillin resistance, we have to fight beta-lactamase inhibition, and a favorable MIC profile. For all of this, when we check amoxicillin clavulanic acid against all of this, we get a good MIC for strep pneumoniae. It is also giving us penicillin susceptibility, H. influenzae, beta-lactamase producing and non-beta-lactamase producing. So when AMC demonstrates a strong activity against strep pneumoniae, depending on the penicillin susceptibility with a higher MIC values in resistance ranges, and shows excellent efficacy against S. influenzae and H. influenzae and M. catarrhales, including good susceptibility in beta-lactamase producing strains. When we look at the clinical susceptibility data, how does amoxicillin clavulanate measures up? For strep pneumoniae, the penicillin is AMC gives us 91.8% susceptibility, while for H influenza again it gives us 97%, and for M catarrhalitis it gives us 98.4%. So we realize that AMC demonstrates consistently high susceptibility rates against Streptococcus pneumoniae, H influenzae and Moxarella catarrhalis, reinforcing its broad spectrum efficacy against key respiratory pathogens in India. When we go towards an effective dosage discussion, the key factor which influences the antibiotic efficacy in time serum levels remain is the time that serum levels remain above the MIC, that is time dependent killing. As we all know, we have been using amoxicillin clavulanate as a 400 with 57 of clavulanate per 5 ml, as it is 7:1 or 8:1, which is the most effective. The dosage 14:1 is something which is new for all of us and is the point of discussion today. 14:1 provides a prolonged drug exposure, serum concentration being 4 μg per ml for more than 40% of the dosing interval. That ensures bacterial eradication. Effectively, treating bacterial infections caused by pathogens with reduced susceptibility to other antimicrobials while minimizing the emergence of resistant strains. So what is this high dose amoxicillin? High dose amoxicillin is actually a higher dose of amoxicillin without increasing the proportionate dose of clavulanate, that is 14:1 of AMC. It gives us high dose amoxicillin of 90 mg per kg per day without clavulanate dose which is increased, that is 6.4 mg per kg per day. The doubling of the amoxicillin 7:1 to a 14:1 gives us 7:2 when the doubling of AMC is done from 7:1, the clavulanate exposure becomes 12.8 mg per kg per day, which is an unnecessary high CVA exposure which has implications for safety and tolerability in children. It is 14:1 is superior to conventional doses in children and is definitely preferred when with acute respiratory tract infections like otitis media, rhinosinusitis and also community acquired pneumonias. So optimizing amoxiclav dosing based on PK and PD ensures that effective community acquired treatment and minimizes the resistance spread. Amoxicillin and clavulanic acid ES, that is 14:1, is the advanced management of community acquired pneumonia. It is optimized for pediatrics, designed to combat community acquired pneumonia in children with a high dose amoxicillin formulation. It gives us enhanced efficacy. It achieves the target of TMIC more than 40%, ensuring a better bacterial eradication. Convenience and compliance. Reduced dosing frequency to twice daily improves adherence. Dual release technology, the bilayer formation ensures immediate and sustained amoxicillin release. And clinically, we have seen the success. The studies in India show 97.16 efficacy against strep pneumoniae, which is a with a also very favorable safety profile. The recommended dose of extended spectrum formulation of amoxicillin clavulanic acid is 90 to 6.4 mg per kg per day for community acquired pneumonia. Let us see the clinical evidence which supports the high dose amoxiclav. The phase 4 Indian data show 98% early clinical response with a very low rates of mild GI side effects. Does this match when we see it in our own practice? Yes, it does. I have been personally using it and I have seen the improvement in the clinical profile on the third day of starting the treatment. Especially I see there are concerns when we discuss ES for the GI side effects, but which are not very majorly changed when we are using basic 7:1 amoxicillin. The big percentage of physicians prescribe 400 mg of amoxicillin to 57 clavulanic acid as the high dose for pediatric patients. So 41.2% still prefer 7:1 dose, while the others are gradually adapting to using 14:1. Let us see the safety and efficacy of high dose amoxicillin and clavulanic acid in children with ARTI. Role of amoxiclav in ARTI. High dose amoxiclav 14:1 is effective for ART. The treatment emerging adverse events, the TEAs are 5.2%, common were diarrhea, vomiting, low appetite, and there are no severe adverse events, and the efficacy, as I discussed, is 98.7% by day 3 or 5. I have discussed this. The phase 4 study assessing the Augmentin ES showed a 98% early clinical response, and between the first 3 to 5 days, and the follow-up phase of the remaining days also gives a good safety and SCR. The guideline recommendations for amoxiclav's treatment, it's the first choice for severe community acquired pneumonia. High dose amoxicillin with or without clavulanic acid is recommended for ARTS. The alternative first dosing, as BTS Children says, in 2011, and alternative empirical therapy in PIDS 2011, IDSA 2011, 2012 and 2013. In other respiratory tract infections.
Time's up, Neha. Time's up. Yeah.
Okay. Can I have a minute? I'll sum up. High dose amoxiclav in acute bacterial sinusitis and persistent otitis media has also been seen to have a good response. As we discussed this already, dosage and administration in pediatric patients, I would not like to waste more time. And two clinical scenarios which I have already included in my talk initially. Age 7-year-old with no medical history, it gave us a good response when 2 days of fever and dry cough was not managed by amoxicillin, and amoxiclav when the higher dose was used, and we got a good response on day 3. I would like to end the talk. Thank you so much.